Okay, Assalamualaikum and very good morning. First of all, thank you from the JKWP, the pharmaceutical division. Thanks for inviting me to give this talk regarding the classification and management of epilepsy. Thanks also the organizing committee. Thanks to all. Thanks for the attendance here, So just now the Tatika gave about the emergency. So emergency is very important. We have a lot of in emergency of the status epilepticus. Now we go to the classification and management as well. Today the theme is purple. So epilim Oh, epilim. Ke bawang? Epilim lah.
Yeah, sort of. It's a universal color for epilepsy awareness.
Oh, okay, sure. And selamat Hari Raya as well. Okay, so we move to the classification management of epilepsy. So this from the International League Against Epilepsy. Bukan football, dia ada league Epilepsy also got league. So this is from 2014, the latest one, 2017. So at least unprovoked seizures occurring more than 24 hours apart. That is the called seizure. Is the first one is the seizure. After that, we call it epilepsy. And one unprovoked seizure and the probability of further seizures similar to the general recurrent risk. At least 60% after 2 unprovoked seizures occurring over the next 10 years. This is the diagnosis of epilepsy syndrome. So the first one is seizure, after that is epilepsy. Okay, we have classification 2017, nanti I pergi further for the important, why we classify it further. This one is the classification, after this is the expanded version. So previously we call it simple partial, complex partial. Now we divide it into the focal, generalized, and unknown onset. So it's aware, impaired awareness, motor, non-motor. Aware means you are conscious. The patient is conscious. They know what happened. Impaired, there is a loss of consciousness. Generalized and unknown onset. Focal means is one part of the brain only involved, and it's focal involvement of the seizure. Generalized means the 2 hemispheres of the brain involved. Unknown means nobody knows what the time of onset. The patient don't know. Patient of course don't know lah. The family members don't know. That is the unknown onsets. So this is the expanded version. Expanded means what is motor, non-motor for the focal, and also generalized onset, motor and non-motor, unknown onset. So after this I have video. We can classify further. We can see sometimes the notes will not symbolize everything, but when we look at the video, we will know. So automatism usually the repetitive movement lah, such as flicking your eyes, and also your hands, fidgeting your hands. And atonic means there is tone but atonic, no tone lah. So suddenly fall. And clonic usually this one. Oh, dia tak ada pointer. Saya pun tak ada pointer. Oh, okay, tak apalah. Clonic and myoclonic, although it's same, it's a jerky movement, but myoclonic is a brief. Clonic is more than 2 minutes. Hyperkinetic and hyperkinetic is excessive motion lah. Tonic means stiffness. Nanti we have video after this. Also, as I mentioned before, generalized means the both of your hemisphere involved. So it's general. Okay, I hope we can play this video. This is the common types of seizure that we have to know. This is the absence seizure. Absence usually the flicking of the eye. Usually it's generalized lah. Atonic means no tone. Kan, suddenly the head fall. Myoclonic is brief episodes only. Tonic is jerky movement, but it's prolonged. This is generalized tonic-clonic. Okay. This is okay. Anybody want to try? Betul-betul bukan buat main-main Okay, can identify what problem, which organ involved lah. Which organ involved? How about the mouth and hands? Kan, this is called automatism. The hands fidgeting. Okay, can you see the mouse? Okay? And also the hands. Automatism. This is a focal onset lah. Okay, banyak sangat video lama tengok nanti. Okay, and then we go to differential diagnosis of seizure based on neonates, young children, adults. So there's a lot of classification. You want to take pictures? Acak satu nanti penat nanti. Okay, can take pictures. Okay, so generalized tonic-clonic, GTC, generalized, is can kill, such as convulsive status peticus, like Dr. Tika said just now. And also it can involve by the patient itself or the other surroundings. Road accidents, drowning, fall from heights. This is GTC. And increased risk of sudden death in young adults. And risk of sudden death in epilepsy, so that means children. And common in patients with GTC than other seizures. So this is a very dangerous part, sudden death in epilepsy. Okay, pregnant women tenfold increased risk of epilepsy-related mortality, particularly so that than non-pregnant women. That's why we have to control the seizure. If genetic, presumed genetic basis for the seizure onset in childhood or adolescent, normal or above average IQ, normal physical examination, may have absent seizure, myoclonic or generalized tonic-clonic seizures, and from the EEG itself. Epilim is the most effective anti-seizure drug. If pregnant woman or childbearing age, Keppra, lamotrigine, and topiramate. Okay, so we can see focal onset is focal, generalized is the whole, usually the whole body because the both hemisphere are involved. And the seizures of unknown onset. So in this case, you hear a noise enter the video EEG room to find the patient in bed, grunting, eyes roll up, all limbs stiff, then rhythmically rejerking for a minute, off camera. So we don't know the onset. This is the unknown onset. Okay, key role of impact. Can we have the impact consciousness and aware in the focal seizure just now, right? So among many possible behavior during seizures, impairment of consciousness has always had a key role in classifying the seizure because of practical importance for driving, safety, employability, interfere with schooling and learning. So somehow, impact consciousness in seizure is not involve the patient itself and the others as well. Okay. Elements of consciousness. Awareness and the memory at the event of the seizure. Responsiveness means you awake the patient, you try to wake up the patient, so there's no verbal stimuli. And sense of self has been distinct from others as well. So you can ask the patient, does he remember on the event? Does aware? Does he understand what people is asking? Okay. Seizure signs and symptoms. Automatic behaviors, automatism, such as flickering, and also fidgeting, fumbling. Emotions or appearance of emotions, extension or flexion of posture, this is tonic, tone. And autonomic means your flush, sweating, and jerking arrhythmically. Myoclonus is rhythmically jerking. Language, your cognitive lead jerks, eyelid myoclonia. Limb, atonic and numb sensations, pausing, behavior arrest, and pedaling. Hyperkinetic means your you punya extreme motion, and also truncation, your spasm. Okay, this one old term. Now we go to new term. Previously just absence, so now it's generalized absence. And akinetic is focal atonic. And then aura is focal aware. Cloning is focal clonic, complex partial. Kita tak pakai simple or complex already. We use complex partial focal impact awareness. and convulsion, focal, generalized, motor, or GTC, tonic or clonic, or bilateral tonic clonic, convulsion. Okay, old term, new term, unconscious, previous one we use unconscious, now we use impaired awareness, partial focal, simple partial focal aware, macam kelas bahasa pula. Okay, complex partial focal impaired awareness, this is a new term yang 2070 punya ILAE classification. So, psychic cognitive, secondary generalized tonic clonic, focal to bilateral tonic clonic, arrest, behavior arrest. Yeah? So we don't use any more partial or complex partial. Okay, what is the rules for classifying these seizures based on our 2070 ILAE? So we want to know the onset, whether the seizure is focal or generalized, and its patient is aware. For focal seizure, we have to classify the degree awareness or not aware. And also impaired awareness at any point. Focal seizures can be focal impaired awareness seizure. Onset. So classification focal seizure is predominant sign or symptoms. Sama ada tonic, atonic, clonic. Do not count transient behavior arrest. Behavior arrest, focal behavior arrest seizure, show arrest of behavior. Motor or non-motor. Motor usually your motor, tonic, clonic. Non-motor usually your autonomic problem. Your flushing. Okay, this is the rules of classification first. The second, why we classify, if we don't know, it's such ambiguous, we can, such as motor, non-motor can be omitted. We can add the other symptoms, such as focal emotional seizure, bilateral or generalized. Okay, so atypical absence is slow onset and in EEG spike wave at less than 3 per second. So we can see from the eye flickering tadi, from the absence seizure. So clonic, BS myoclonic, clonic refer to sustained rhythmal jerking, myoclonic regular unsustained jerking, and a brief episode, that is myoclonic. Eyelid is absence with eyelid myoclonic refers to forced outward jerking eyelids during absence seizure. Okay, we have examples. I think I have 5 examples for the why we have to classify the seizure. I have no questions like Dr. Atikah lah. I have the examples only. So we can try. A woman awakens to find her husband having seizure in bed. The onset is not witnessed, but she is able to describe bilateral stiffening followed by bilateral shaking. So is it what type of seizure? Focal, generalized or non-onset? Dah ada dalam tu dah. The woman awakens, the onset is not witnessed, but she is able to describe bilateral stiffening. So the senang je, focal or generalized or unknown? Unknown lah. Okay, this is senang kan seizure kan? It's unknown onset. It's a tonic clonic. So kalau old, yang lama-lama punya, before 2017, is unclassifiable. So we don't know the onset. So same patient, the EEG shows a clear right parietal slow wave focus and show right parietal region of cortical dysplasia. Okay, is tonic clonic because of the symptom, the sign itself, although is lack of observed onset because of focal strategy has been identified, and the overwhelming likelihood is that the seizure at focal onset. The old classification is unclassified. Okay, so is unknown onset. Case number 2, 24-year-old woman describes seizures beginning with 30 seconds of intense feeling that familiar, got music. She can hear other people talking, but afterward realized that she could not determine whether they were saying. After an episode, she is mildly confused and has to reorient herself. What type of seizure? Focal ke, generalized ke, unknown? And is it what type of seizure? Is it motor or non-motor? Okay. Is impaired ke, awareness or aware? After episode, she is mildly confused, and mildly confused after episode tu, maksud dia? Post-iter lah. So she can hear other people talking, but afterward realize that she could not determine whether they were saying. They can realize tapi tak boleh tahu what is people talking. Okay. Kita jawapan dia. She is mildly confused and has to reorient herself. Seizure will classify as focal seizure with unaware, impaired awareness. Even though patient able to interact with environment, she cannot interpret and confuse. Okay. So because this is autonomic and also is focal seizure with impaired awareness, cannot reorient herself. Okay, a 22-year-old man has seizures during which he remains fully aware. He can feel the hair on my arm standing on the edge and feeling being flushed. Is focal ke, generalized ke, unknown? Is aware ke, impaired awareness? Aware, okay. For motor ke non-motor? Okay, non-motor lah. Is autonomic kan? Yes. So this classified focal, aware, non-motor, autonomic. You dah ada semua sentence dalam tu. Okay. The diagnosis of seizure must be complete based on the classification. Macam kita punya dengue jugalah, kena ada lengkap semua. Same. So dulu we use previous one is old version. Now we have focal, aware, non-motor, autonomic. Atau you boleh tak payah guna non-motor pun focal, aware, autonomic. Okay. So if previous one simple partial autonomic seizures. So kita tak guna dah partial. Okay. I think last one. Not last slide lah, last question. A 35 years old man with juvenile myoclonic epilepsy has seizures beginning with a few bilateral arm jerks, followed by stiffening of all limbs and then rhythmic jerking of all limbs. Focal, generalized or unknown? Okay, what type of generalized? Okay, so masa dah mencemburui nampaknya. This would be classified as generalized myoclonic tonic-clonic seizures. And not corresponding single seizure type as in the old classification, because we see because it's myoclonic, because it's few only onset, few regularly spaced jerks, and stiffening all limbs and rhythmic, and it's generalized because all the limbs involved. Okay, so we go to ada menggambar tak ada? Okay, we go to the treatment options. So what the treatment that must the patient with seizure have is focal. We want to classify first. Is it focal? Is it generalized? So is focal, such as your sensory motor. This is the medication that we can use: carbamazepine, gabapentin, oscarbazepine, phenytoin, vigabatrin, and lacosamide. But generalized onset, patient must have epilim. Epilim is the first for the generalized onset. Or lamotrigine, topiramate, levetiracetam, zonisamide, perampanel. I think yang the lacosamide, zonisamide, perampanel we don't have. I think in us lah. So for the absent etoxicima also we don't have. We can use epilim. Okay, this is the treatment options by the seizure type. So that's why it's very important you classify patient is focal or generalized. Is generalized seizures, epilim is a must. Macam you punya asthma, steroid is must. So this same together with the epilim. Unless the patient is childbearing age, pregnant woman, so we have to go to levetiracetam, lamotrigine. Okay. So if focal onset, such as your single hemisphere involve carbamazepine, phenytoin is a good option. But the rest we don't have kan, I think kan. The lacosamide tak ada kan. Okay. So side effect and benefit of anti-seizure medication. So this is we have to aware in the klinik kesihatan because of the stable epilepsy we send to klinik kesihatan lah. So dekat KK we have Kepra kan? Oh tak ada so dia kena hantar ke HPJ juga. Oh we don't have Kepra Okay. Later we can send lah. So senang for maintenance. So Kepra, usually the change in mood or behavior, that is the side effect lah. So we have to, kalau patient tu ada MDD, you tak payahlah bagi Keppra lagi. Kan? So we have to advise the patient. And topiramate is good for the mood, more significant weight loss, and help to prevent migraine as well. Yeah, there is side effect benefit. Epilim, teratogenic, but not good for the mood. So, but good for mood. Carbamazepine, as usual lah, the side effect. SDS, agonostosis, but good for mood. And also is treatment for trigeminal neuralgia. So carbamazepine is a focal. That's why it's very important to classify. It's a generalized seizure. If we give carbamazepine, it can worsen it. Yeah? So what is the medication good for mood? Okay. The rest is good. Only a Keppra is not good. Kan? So Keppra is not good for the mood. So you have to be aware of the patient's conditions. Kalau ada problem ke, masalah keluarga ke, nak bunuh diri ke, tak payahlah bagi Keppra lagi. We can change to other episode. So that's why you have to manage patient as a whole in the epilepsy. The side effect of medication is very important. Okay, this is optimum dose for anti-seizure medications. Lamotrigine 100 BD, Keppra 1000 mg BD, carbamazepine 400 mg BD. So if not, this is the optimum dose. And TDM that we have here only phenytoin, epilim, and carbamazepine. So in special circumstances, in patients having phenytoin and also patient has CKD, because the phenytoin is bound to albumin. So in CKD, albumin low. That's why the TDM of phenytoin will be low. That's why patient on phenytoin, we have to check the renal function. It's bound to albumin. So the TDM can be low. In patient CKD, the TDM will be low because the albumin is low. Okay, so how you choose the correct first anti-epilepsy drug? So newly diagnosed, you have to classify whether it's focal or generalized. Focal is, you nak bagi apa tadi? Carbamazepine, yang kita ada carbamazepine, phenytoin. If you have generalized, what we have to give first? Epilim first. Okay, first drug 47% seizure free. Second drug 40% seizure free. So, and then refractory. So, the correct first AED to depends you classify correctly or not, whether it's focal or generalized. So, you can give medication on focal and generalized, and also you know the side effect of the drug itself. Okay, fetal anti-seizure medication, fetal development and long-term cognition. Polytherapy carries a higher risk of fetal malformation than monotherapy. And is even higher if the combination contains valproic acid. The recommended practice will prescribe single drug therapy at lowest possible dose. Study has shown that higher doses of anti-seizure may lead to impact verbal and non-verbal ability, and regular assessment of cognitive function for children who have fetal exposure to anti-seizure medication is recommended. So that's why is the fetal development and patient is childbearing age, in woman childbearing age, in pregnant woman. So we have to avoid all the phenytoin, epilim. So that is why we give Keppra and also lamotrigine. That is those medication that is safe in pregnancy. Okay, we have the medication. Is refractory, is unable to control with multiple medications. We can do epilepsy surgery. We want to have the patient seizure free because there's complication. There is anoxic brain. A patient can have a vegetative state is not treated. So treatment option for patient with medically refractory, based on the MRI, pre-surgical evaluation is crucial for patient selection and ensuring good outcome, and depends on primary pathology and location if there is lesion in the brain. Prognosis depends on pathology and concordance of pre-surgical data. Prognosis is the most favorable is patient has glioma. The cortical dysgenesis is less favorable. Okay, tadi Dr. Atika although mention also ketogenic diet kan, therapy for epilepsy. For epilepsy, ketogenic diet is play the important role as well. It's high fat. Nanti I will show the pictures. And more importantly, low carbohydrate. And medium chain triglyceride and low glycemic index. Oh, okay. Highly effective for GLUT1 deficiency syndrome and pyruvate dehydrogenase complex deficiency. It also variable response in other epilepsy syndromes and patients. Okay, this is the contoh of example of ketogenic diet is high fat. So healthy fats lah. Tak payah ambil lemak ayam semua tu, lemak ayam, lemak lembu tu. So it's if weakness already unknown. Usually we can change the classification itself lah. It's weakness already. Epilepsy to type of mana?
Epilepsy type or category not specified. He is on 2 ASM and seizure free for more than 2 years. Can we taper dose of ASM or further investigate before doing so? If the category is not specified, but he's on 2 medications and seizure free, can we taper down or do we need to investigate? Keep them?
Okay. Yeah. Okay. Investigation is very important. We have to investigate why this patient has seizure. So is it epilepsy itself, or is it focal? Is it from the brain itself? And is 2SM and seizure free for 2 years? Yes, more than 2 years usually we can reduce down the epileptic medication. And same goes to your punya driving ke. Usually if you're driving or anything that going to your machine, usually it's 2 years epileptic free without anti-seizure medication. It same goes. So if 2 years, we can reduce further down. Is it safe to be on therapy for patient planning for pregnancy? So yang safe the lamotrigine and Keppra lah. The rest is teratogenic. So cannot add on another things because it's teratogenic. So Keppra and your punya lamotrigine. Do you use that same vessel for all patients for a group of apa tu kat ujung?
For a group of patients only. Can you use it for all patients or just certain types?
Oh, tak payahlah patient diabetes pun nak tengok sudet. For the epilepsy clinic lah. Do you use sudet vessel for a patient or group of patients only?
Do they mean different epilepsy types? Maybe just the focal ones. Just the patient who's having focal seizures.
Oh, most probably we use all for the epilepsy lah. Tapi yang lain-lain tu we don't use lah.
How to confirm focal or generalized onset? Okay, next
banyak
one.
Soalan dia.
Banyak.
Kejap tak tahu yang mana satu.
How do you taper the medication down after 2 years? Both of them reduce dose one by one. Which of the two do we taper off first?
How do you taper medication down after 2 years? 2 years both.
Sekejap. One by one, or which one? Which one do we taper first? If there are 2 medications or several medications.
Oh, okay. Depends on your what type of medication lah. Such as you have generalized kan, you have your EPILEPSY and you have your EPILEPSY, or you want to add on your Keppra or lamotrigine. So what the patient must have is your EPILEPSY. So you can reduce the other first. EPILEPSY must have. Macam you punya convulsive phenytoin juga.
Okay, maybe the last 2 questions before we're having our break.
Dah kan jawabkan tadi.
Yang the second. Just 2 other.
How to confirm EEG? Lepas tu, is it safe to be... Yang polytherapy pun dah jawab tadi kan?
Okay.